All right, our first presentation tonight is by Dr. Jack Vernamonti, who is a Surgical Innovations and Critical Research Fellow at the University of Michigan in Ann Arbor. His talk is titled The Diversity and Demographics of APSA Members, Understanding Our Identity.
Hello, and thank you for allowing us to present our work. On behalf of the DI committee, we have nothing to disclose. Currently, pediatric surgery is facing multiple complex problems regarding healthcare disparities. Public insurance, lower household income, and female sex are independent predictors for undergoing umbilical hernia repair earlier than recommended guidelines. Black children have higher rates of perforated appendicitis, as well as surgical complications and costs associated with that disease. Black children are also less likely to receive pain medication for appendicitis, even when matched pain scores compared with white and Hispanic children. Black children have higher mortality and longer hospital stay after traumatic brain injury and are more likely to experience trauma. In addition to active disease states, healthy Black children have a 3.5 times increased higher 30-day mortality for elective operations compared with white children, even when matched by socioeconomic status. These are complicated problems that need to be solved by pediatric surgeons that include a diverse group of people in thought and identity. The reason that this is necessary to solve the problem is that our demographic diversity begets our cognitive diversity. Our cognitive diversity is shaped by our demographic identities, and our identities change how people interpret data and innovate solutions. This has been reproduced and published in several fields, including banking and finance, where more diverse teams perform better. However, while APSA does collect some demographic data, it is incomplete in certain fields and is not always filled out or adequately representing the knowledge gap. Our hypothesis is that we would identify areas where APSA excels in cognitive diversity, as well as demographics that are underrepresented. To answer this hypothesis, an investigator-created survey was anonymously distributed to all APSA members, of which 423 responded, for a response rate of 27%. While low by other standardized survey criteria, it is one of the largest response rates in absolute number through the Outcomes Committee. Sorry about that. And as you will see, the relative representation across identities, practice types, and academic ranks is broad, and we believe the results are generalizable and can serve as an adequate sampling. The scope of demographics that we added to the survey assessed include gender and sexuality, race and ethnicity, language, heritage, religion, and academic rank, as well as practice settings. For identity demographics, 64% of the respondents were men, 97% identified as heterosexual, and 75% identified as white. 13% of members identified as Asian, and 5% of members identified as Black. There are at least 10 different religious identities represented within APSA. 50% identified as Christian, 12% identified as agnostic, 11% as Jewish, and 10% identified as atheist. Respondents are conversant in over 23 non-English languages, with Spanish and French being the most common. 93% of the respondents were American citizens. However, 37% had either one or both of their parents born outside of the United States. Similar to other professions, most respondents had parents with at least a bachelor's degree. However, 21% had parents with an associate degree or fewer schooling years. Shown here was the identity demographics of respondents compared to United States Census data and AAMC matriculant data for those entering medical school. Comparing to US Census estimates, members were underrepresented, Black and Hispanic members were underrepresented compared to Census data, and women members were underrepresented compared to Census data and AAMC matriculant classes. Both of those estimate about 50% women. Here are demographic identities represented across academic promotion tiers from clinical appointment, assistant professor, associate professor, and professor. There was no statistical difference in race or ethnicity identity across the academic promotion tiers. However, those with Asian identity had a decreasing relative representation as it moved from clinical appointment through to professor. However, for gender parity, there was a statistically significant difference in the rank of professor, with only 18% of professors identifying as women. In conclusion, through the survey, there are areas such as religion, language, generational status, and family education where we have significant cognitive diversity. However, comparing to national and medical student demographics, Hispanic, Black, and female identities are underrepresented amongst our respondents. 18% of professors in this group identified as women. Efforts on recruitment and promotion are important to ensure that we have the cognitive diversity necessary to tackle the complex problems and have representation from all represented and affected member identities. Thank you very much. I'm happy to take any questions.
Thank you. That was a nice presentation, and I think an important look into the demographics of our membership. I was wondering if you were able to break this down based on years in practice, specifically questioning whether or not we're doing a better job increasing diversity in some of the more recent graduating classes than in people that have been in practice longer. And if that may carry over into impacting some of those promotion issues, like you have here on this slide specifically, as more of the younger generation advances through the ranks, maybe we see a more better parity with men and women in professor roles.
Mm-hmm. We do have years out of practice and out of training, and we did break down into 5 and 10-year buckets. We do have that, but as far as the representation, we thought that the academic rank carried, while it's not directly correlates with your time in the field, that it had to do with other factors within institutions that recognize promotional factors or packets or recognize your contributions. So we just stuck with that for this analysis. But I will say, I think we do, at least from this subset, a pretty good job of promoting underrepresented identities such as Black and Hispanic members through the ranks of getting them into the clinical appointment. It was the same, no difference in the percent representation of promotion. There was a trend towards decrease of Asian American and Pacific Islander identities, but the problem is probably getting people into the door, and our comparative numbers are lower compared to census data, but it even shows in matriculant medical school classes that Black and Hispanic members are still underrepresented compared to census estimates. So it tends to be probably for this a pipeline issue for that.
Along those lines, I noticed this matriculant data is from 2019. Are there data from earlier years, just considering how long it takes to become a member of APSA? Have the matriculant data demonstrated a trend upwards in representation over the last 2 decades that might just reflect a delay in people getting to APSA?
I don't know. Historically, I did not look at AAMC trends over time. I do know that there has been, from papers reading in the literature back, that a little bit of a plateau in bringing in certain member identities, but the AAMC matriculant class for a while has been closer to 50%, particularly for gender parity, and that seems to be, and the surgical residencies have caught up, are still behind a little bit in that, but not at the same 18, sort of 82% that we saw at the professor level.
Thank you.
All right, thank you so much for your time.